So it is an absolute pleasure to address this topic to this room. I do want to clear the room immediately, though, and say that I don't consider myself an expert in AI or machine learning. I use it daily in my work. We're going to have a panel of true experts. But as we go through, what I'm going to try to do is to point to different resources that have helped me along the way as I've learned how to use this and integrate it into my research. And so when I was first invited to give this talk, the first thing I did, obviously, was to go and look for a black turtleneck to try to give off the Steve Jobs vibe. I don't own any black turtlenecks, but thankfully, using a simple prompt and image-to-image generative AI, you can come up with a pretty good likeness. So this is the vibe that I'm hoping to set for the rest of this talk. So in general, artificial intelligence is the ability for computers to perform tasks that are usually done using human intelligence. That might be things like learning or reasoning or decision-making. And I think that all of us would agree that it is really hard to walk down the street without seeing some ad saying that this is driven by AI, powered by whatever algorithm, or if you review grants, the pitfalls and alternative is always going to be some vague reference to how AI is going to solve whatever didn't work in the original aims. And I think this is a little bit like Job's banana stand in Arrested Development, where he's saying a frozen banana that won't make you sick and kill you. Just because one algorithm is saying that, yes, I'm getting looks. I was told not to use this one. But the idea, right, that just because one thing is highlighting that, yes, it uses AI, it's ubiquitous. It is driving almost everything we do, right? So if I get a fraud alert saying my credit card, someone tried to buy a Maserati in Nebraska using my credit card, the way that's working is AI is looking through. It's looking through my normal patterns. Buying irresponsibly on my credit card maybe fits. Purchasing in Nebraska doesn't fit. And so it flags that as being something that is fraudulent, right? So even if they don't advertise it, Chase is using it, everyone else is using it. Artificial intelligence has a number of different branches, but I think one of the biggest branches that we use within pediatric oncology or research in general is machine learning. And put very basically, machine learning is the application of algorithms and statistical models that learn from data to identify patterns and then make predictions and decisions without being explicitly programmed for each task. And I think one of the concepts that for me was a little bit hard to tease apart is that just sounds like statistics. One, they're very closely related. And I think when I pop up the next slide, you'll say, oh, I always thought I was doing stats, but I'm actually doing machine learning. One, I think, key difference is that with machine learning, we think of those as algorithms that learn from the data to make predictions. In other words, the thing that is being prioritized is the predictive accuracy. Whereas in statistics, we're often trying to explain data, really prioritizing interpretability rather than will this be generalizable and able to predict the next set of data. And so when I think about machine learning, I tend to think of it in sort of two larger branches. So supervised machine learning algorithms and unsupervised machine learning algorithms. I think looking at this list, most people in this room have probably done linear regressions, logistic regressions. Those are all examples of supervised machine learning. The idea is that you have labels, right? It might be cancer or healthy, and you're fitting a model that is able to predict and generalize to the next set of data based on those labels. You can also have unsupervised machine learning. We've also probably used a lot of these, right? It's surely at some point in some lab meeting you've been asked to look at this in a PCA or maybe to single cell data, so you have to do a t-SNE, right? And so unsupervised data, the only difference is that it's not labeled going in, right? It is looking for patterns regardless of ground truth, and then you or other machine algorithms stacked are going to help interpret that data. And so again, I use machine learning sort of day to day in the lab. One example, these arrows aren't lining up, would be using support vector machine learning. So an example of this would be taking circulating proteins, looking at each protein and how can we integrate those together to come up with a signature predictive of a disease state. Using non-negative matrix factorization. A lot of the research I do is in liquid biopsy. So looking at circulating fragments of DNA that have different characteristics. So using non-negative matrix factorization, I might look at the end motifs on those circulating fragments and say, oh, well, if this end motif has this % representation, this other one has this % representation, put together, that signature is very suggestive of MPNST, malignant peripheral nerve sheath tumor, or a benign plexiform neurofibroma. And so using non-negative matrix factorization, we can start to tease apart those signatures. Similarly, you can look at fragment sizes. Cell-free DNA fragments are different sizes. A lot of that has to do with the biology of the tissue that it's being expressed from. And so you can use non-negative matrix factorizations to start to tease apart the signatures of the fragment size distributions that might fit with cancerous or non-cancerous. And then hidden Markov models, again, this probably underlies a lot of what you do in the lab anytime you apply a different algorithm. But for me, I use this all the time just to try to estimate the tumor fraction or the percent of circulating tumor DNA within a tube of blood using coffee number alterations. And one thing I do want to point out here is StatQuest is a fantastic resource. It's free. You're going to really question me when you first open it up because he sings all of the lessons, but you will learn a lot from that. And I think that as you sort of try to approach these different algorithms, using StatQuest to help march you along on that is really, really helpful. And you're really going to question me when the first time you use it, but it's great. Regardless of the type of machine learning, the basic principle is the same. You're trying to take training data, whether that's supervised or unsupervised, fit it to a model, and then apply that model to a validation or a novel data set to come up with a prediction. There are some differences. So if you're using supervised training data, a lot of times there's going to be iterative refinements to try to approximate your end prediction or your end model a little bit better. But these are all individual algorithms that I presented before, but you can also start to use combinations of multiple algorithms to have more robust data and potentially data that is slightly less prone to overfitting, which is always an issue, right? It's easy to make an algorithm that can describe the data in front of you. It's really hard to then generalize that to a new data set. And so one of the principles of that is something called bagging, or bootstrapping would be a type of this as well. And here you're training multiple models on different subsets. Random forest is a really good example of this, right? So you take the data set, you split it into multiple sub-data, and then you have decision trees, which I think you can clearly see how that works just based on this image. Each of those come up with a true solution, and then you have a majority vote at the end to come up with the best fit based on all of these sub-data. Another kind of ensemble is boosting. This is similar. The idea is that you have a bunch of weak predictors or weak learners, right? But by putting them all together, you can actually come up with a much stronger prediction. So here, instead of using the big trees, you can see you have a stump, right? You have one truth split into two different predictions. And so boosting iteratively trains each model so that each model below tries to fix any errors that were made in the prediction before it until you get to a point where you're approximating your data set well, and hopefully it generalizes. And I think the most basic form of this is stacking. So this is the meta model. So here you're literally just combining different predictions from multiple data sets. And the key here is that they can be using multiple different types of algorithms. So potentially you're a little bit less prone to overfitting. So on the right is an example from a paper we have in submission right now using, so for the SARCO-3-1 trial, so using different types of machine learning algorithms. So I-core-CNA, hidden Markov modeling underlies that, fragment size NMF, non-negative matrix factorization, binwise fragmentomics is lasso regressions, and then F-profiles is non-negative matrix factorization as well. But what you can see is that when all of those are pieced together, you will come up with a pretty good predictor as to whether there is indeed cancer in purple or no cancer, yellow, present. And that's just based on a simple majority vote. There are a lot more complex ways you can integrate this data, and we'll, of course, work on that. Finally, a subset of machine learning is deep learning or neural networks, right? And I think of this as sort of semi-supervised. So we talked about supervised, we talked about unsupervised. In deep learning, often what we'll have is a subset of that data that's labeled. So maybe 10% of your data is labeled. It's going to try to work forward to figure out how to best approximate that data and then label the rest of that data as well and to come up with a good predictive model based on that. So this is an example that I borrowed from StatQuest. But the idea is that maybe you have a new medication and you have a low, medium, and high dose. Your low dose, they don't respond. You can see that on the bottom. Your medium dose responds, but then your high dose is, again, non-responders. So how can you best predict on new dose levels whether the patient is likely to respond or not? You could try to fit it linearly. but that's not going to work, right? We don't capture the high dose. And so if you do a squiggly line, you're able to capture that data. But the way you come up with that squiggly line is actually often going to be through neural networks. The idea, and this is a huge simplification, so I apologize to all the panelists who will be up here, but the idea is that you have an input and you're trying to come up with different segments of that line through what in yellow would be called the hidden layers that approximate the actual curve that fits your data. And so you can imagine that if you remember back to your basic algebra, you can change your slope and your intercept. So here we call it weight and bias, but you can adapt those parameters to change the shape of that line, and then you can put those together in a puzzle so that you end up with a squiggly line explaining your data. This can obviously get very complex with more complex data, but all of those are then surmised and you have a prediction at the end of it. This was another reference that I was told not to put in, but I'm going to not apologize for this one because I think it demonstrates it well. If you have not seen the show Silicon Valley, I highly recommend it. I will stand by this one. But if you have seen it, you might remember that there's an app that they developed called Seafood, right? And the idea was that Zhen Yang scraped the internet for pictures of hot dogs, and you could take a picture and it would tell you whether it's a hot dog or not a hot dog. It's a discriminative model, right? Obviously, you're not going to scrape all of the pictures of hot dogs from the internet, but you can train on a subset. So then you can put in a hot dog or a picture of shoe, and it'll tell you hot dog or not hot dog. So I think that's a basic way to think about it, but you can also come up with more potentially pediatric oncology focused ways to use neural networks as well. So for instance, this is an example of a project that we're currently doing, and there is a poster on this that builds largely on the work from Javed Khan and David Milewski's group, where you're taking histologic slides and you're using a neural network to develop predictive features from patches of that slide that might suggest a mutational background. So in this example, we're trying to take a slide from a plexiform neurofibroma from a patient with NF1, and we're trying to decide whether it has CDKN2A mutations just based on what it looks like histologically. And that is an important diagnostic marker because now if you have a CDKN2A mutation, that is considered an ANUP, which is a surgically actionable lesion. If you don't have it and don't have histological features, we just watch. And so, for example, you have patches that cluster to the CDK2A wild type on the bottom and patches that cluster to the CDKN2A loss on the bottom. And what's really interesting is then we had a pathologist look over these patches. It looks at cellularity, architecture, but one of the things that we often comment on is nuclear atypia. And she said that that did not seem to be one of the things that was stressed in this predictive model. It's something that we've commonly struggled with in NF1 because we often will have a path report that says plexiform neurofibroma with nuclear atypia. And as clinicians, we tend to say, that sounds like an atypical neurofibroma. Maybe we should do surgery. Turns out that might not actually be predictive of what we think is the actual driver of malignant potential. And so discriminative models are part of deep learning. Large language models, generative AI also fall into that category. I'm not going to talk a lot about this here. Instead, I'm going to start introducing topics that I'd like to talk about with the panel. So I think there's a lot of potential for AI in pediatric oncology. So you can imagine that not everybody is going to have the ability to do sequencing at their site or to have experts review the pathology. But if we're able to come up with an algorithm where people can just take their normal standard slides, scan it in, and either analyze it locally on an on-prem algorithm that we've developed or send it to a central location where it can be processed, then all of a sudden you might be able to improve access to advanced care and advanced diagnostics. It also might improve risk stratification and prognostication. We as clinicians are okay at looking through and saying, oh, okay, this is leukemia. There's whatever inversion. I'm clearly not a leukemia doctor. There's multiple characteristics that make me think this is a high-risk cancer. But there's also a lot of other patterns in that blood that might be predictive as well. And so maybe we can start to tie all that together and integrate it using genetic, radiographic, molecular, and clinical data to come up with better risk stratification that better describes each individual patient. Also, novel drug discovery. We had references earlier to using alpha protein to try to predict where drugs will bind and protein structure. We can absolutely use that during AI, both to predict mechanisms of resistance and also new targets. And then large language models might be useful in helping match patients to trials. So potentially we can look through large sets of data and say, this person would be a good candidate for trial X, Y, or Z, which their personal oncologist may not be as familiar with, but this is a way to start to decentralize or democratize that access. There's also a lot of obstacles to using pediatric oncology and AI. So pediatric cancers are rare. Training sets are going to be limited. There's also a lack of diversity in general in our training data. I think something that we talk about as genomicists all the time is that we still map to HG19 or HG38, which is largely populated by white European descent people, right? So our reference may not actually accurately describe many of the patients who we're trying to extend or generalize this to. That is a problem when you're looking at one patient. It might be a huge problem when you're training models on that and trying to generalize. The other part is that we know that people of African descent are more likely to have like benign neutropenia, right? So normal lab values might vary. So as we start to put in different features, there might be a lot of just demographic variations that will provide noise to the model, but are actually not relevant to the outcome. There's a lot of heterogeneity of data, right? So if we're talking about sequencing data, we use TSO 500. Johns Hopkins has their own 500 gene panel, which is related, but not the same. And every institution has their own flavor or proprietary test, right? So trying to actually lift that data and harmonize it so that you can harness it and make larger predictions is challenging. And then, of course, data privacy, right? AI described real characteristics that you can try to de-identify. Genomic data is really hard to de-identify, right? And so there's a lot of ethical considerations there, especially when we're talking about pediatric patients who might be able to assent, but not necessarily consent or understand the full implications of what providing their data means. And so with that said, I'd love to introduce our panel of speakers. Generative AI again helped me with this. I had no consent for this, so hopefully I'm covered by the CCF picture release, but if Dr. Marius Linguraru from Children's National could come up, Dr. Joe Murray from Johns Hopkins, and Dr. David Milewski from National Cancer Institute, please.
Thank you, Taylor. First of all, thank you for making us look smarter, and in my case, more handsome as well.
I had to put glasses on.
And thanks for the invitation to be here. This is a great meeting, and I've enjoyed very much hearing the presentations today and your introduction to AI. And I know, would you like me to go first, maybe through my slides? I see that they popped up there.
I apologize. I did ask everyone to just give us a brief overview of their work. So yes, we'll do that first, please.
So I just wanted to say a few words, and I think Taylor made already a point towards how AI is equitable and actually how it is not in many cases. And this is one of the obsessions that I have in the work that I do. How do we use AI in a more equitable way for children? And children often have rare diseases, so patients with rare diseases in general. And I wanted to show you just very briefly some of the examples of recent work that we're doing with my team, and starting with the definition of what I think equity is, and equity in healthcare is really important. And these are the 4 keywords that somebody smarter than me put in the presentation, but accessibility, availability, fairness, and quality and efficiency. And this can mean a lot of things, but one of the things that it means is access to specialists. And for instance, clinical geneticists are very rare in the world. So one of the projects that we're working, and you can find, I included there some references to some papers as well we published if you want to learn more, because I'm going to go through this very briefly. We have a newborn screening program that we're implementing right now in Kinshasa. We work with data from 30 countries to identify dysmorphia. And the way this is done is also because AI has to work well, and I'm looking for my smartphone, it's here somewhere. So we take pictures of newborns and we identify if there is dysmorphia. In Kinshasa, we do a mouth swab as well, and we can tell if they have trisomy 21. But if you want to try that, I'm not going to tell if you have dysmorphia, but I can show you how we can measure without hands-on your patient biometrics in a matter of seconds. So come and see me afterwards if you're interested in that. Also, in terms of accessibility, we're looking both for equipment and, again, interpretation specialists. And this is a story about a program that we are doing in Kampala, in Uganda, where rheumatic heart disease is endemic. This is one of those diseases, right, that we took good care of in the United States, but in many other parts of the world, equitable healthcare and therefore equitable AI doesn't exist. So we have a small probe, ultrasound, same size as this, that is plugged into a tablet that talks to Bluetooth to a laptop, and in less than 1 minute, you get by the child a diagnosis of rheumatic heart disease. And now we're starting a program. We attached ourselves to a big screening program that is going to look at 200,000 kids over the next couple of years. Also in availability, imaging. A third of the world has zero access to any kind of radiological imaging, right? And we're talking about basic ultrasound or chest x-rays. When it comes to MRI, that is something that is a lot more rare. And this thing that I put on the screen there, which one of my colleagues calls R2D2, it's a portable ultra-low field MRI. And again, I invite you to come to Children's National. We have one that is designated for pediatric care, but what this project does, this is funded by the Gates Foundation, collects data from about 30 sites in low resource areas. And what we do, we take a machine like this, which you can plug right here on the wall. It's portable with a joystick. You can move it to the hospital. You can put it in a truck, and you can image the head of a child or an adult. But however, all of this comes with, I should say, it's 10 times lighter, 10 times cheaper than your typical MRI machine. But that comes at a cost as well, image quality. So we use AI, and I can show you how we actually make images that look very noisy appear a lot like what would be a Tesla image through this. And when it comes to fairness, kids are not represented in research at the same level as adults are. Although about 27% of the world population is pediatric, only 2.4% of the publications and studies that include AI also include kids. And this is an example here from a study that was published in Nature Medicine a few years back, where we looked at more than 20,000 patients with COVID, 16,000 patients from more than 20 centers around the world. The only center that participated in this with pediatric data was Children's National. Again, because we don't have the same level of technology, we don't have the same level of expertise, and we don't have access to kids. And that answers one of the first questions that you asked as well, Taylor. What's one of the big hurdles? Access, right? Access to patients and to data. So quality and efficiency, and here I wanted to show you just something briefly that is much more related to pediatric oncology. I've worked for a number of years in pediatric neuro-oncology, and we put together with colleagues from a number of institutions, including the Brain Tumor Network. You see some of the big clinical trials, but also top pediatric hospitals. We have a challenge where we make data public from kids with brain tumors, and we encouraged everyone to develop algorithms for the public good. 2 years ago, when we had this first edition, my team won the competition for the volumetric assessment of pediatric brain tumors. So we're very encouraged by that. And what we did then, and it's what I'm showing you here, we put this online. And you can access this at the website that I showed there on the right. You can upload your MRI. We don't keep any of this data. And in a matter of minutes, you will get an automatic segmentation of high-grade gliomas, and you get the components of the tumors and the volumes of the components reported in this web app. We also do data harmonization for MRIs, and this is another app that is available up there. And at the end of this month, at the Children's Tumor Foundation meeting here in DC as well, we launch another one for optic pathway gliomas. And because data, again, another point of access to data and vulnerability comes from access to data from patients that live in low resource area. Last year, in the fall, we participated in a competition. You see my team there on doing automatic analysis of brain gliomas from patients from sub-Saharan Africa. And we won, again, that competition. So this is, again, an algorithm that we plan to put public for the greater good. And maybe I will stop here and ask the...
I think that's perfect. Thank you. And yes, I think all of the nephrologists in the group are looking at each other when you're showing the segmentation, because volumetrics is a big issue in our field, and that's really exciting.
Great. So thanks for the introduction. That was really exciting. And it's cool to see also that these models are becoming available for people to use. I think that we can talk about later in the panel, but making these models accessible is really going to help push the field forward. So I'm David Milewski. I work in Java Cons Lab at the NCI, and I've been part of a large collaboration between the NCI and Children's Oncology Group to develop and then start to integrate deep learning models into the clinic when it comes to histopathology images. And so our main focus has been on rhabdomyosarcomas for a few different reasons. One being that for really any model that you're going to be training, you need to have a high quality and high quantity of data to use for both training and for testing. And so rhabdomyosarcoma being one of the more common pediatric solid tumors, this was a great candidate for us to start building some different models out where we can look at things like histological classification, mutation predictions, and even some of the outcome predictions that we ended up pursuing. So that's one reason to focus on rhabdomyosarcomas. Another reason, which came out of a series of genomic studies that Java Cons Lab and had performed with Jack Schern, and there's also some other groups, where they found recurrent high-risk mutations in rhabdomyosarcomas that are now being integrated into risk stratification. And so when we look backwards the past 30 years of progress in the rhabdomyosarcoma field, a lot of the progress that we've seen has not necessarily come from better therapies, but it's actually better overall clinical care and then better risk stratification. So we think that however we can maximize risk stratification, that might be a really good return on investment. And so the different high-risk mutations that we focused on are FOXO1 rearranged rhabdomyosarcomas, which happen in about a quarter of rhabdomyosarcoma cases. And then two others are p53 mutations and MyoD1 mutations. So the idea here is that if we're not going to be using next-gen sequencing to identify these mutations on a newly diagnosed rhabdomyosarcoma, can we use an AI model to kind of flag a new rhabdomyosarcoma patient that might have one of these very high-risk mutations? But there's also another interesting characteristic of these mutations, in that each of those three high-risk mutations already have an established histological pattern that's associated with them. So for FOXO1 fusion-positive rhabdomyosarcomas, it's a small round blue cell tumor, but they'll typically have this alveolar cell architecture to them that a pathologist could pretty readily recognize. P53 mutations, they're not that common at diagnosis, maybe 5 to 10% of rhabdomyosarcomas, but these are very high-risk mutations. And in the case of rhabdomyosarcoma and many other cancers, there's anaplasia that can be readily picked out by pathologists. And then lastly is activating mutations in MyoD1. So these are very rare but very aggressive tumors. And they have this characteristic spindle cell morphology. Sometimes there's sclerosis within the tumor. And a lot of these MyoD1 mutant tumors do get missed because it's such an infrequent mutation. So it's not necessarily screened for in the current state where not every tumor is being sequenced. So we developed these predictive models that can take kind of ground truth data from a large cohort of rhabdomyosarcoma patients and start to identify what features correlate with the presence or absence of these high-risk mutations. And so the cohort that we used had about a little over 300 different rhabdomyosarcoma patients, where we had a whole slide diagnostic H&E image, but then we had their accompanying clinical data. So things like their outcome, their stage of disease, their risk group, whether it was fusion positive or fusion negative, or whether it was wild type or mutant for any of these high risk mutations. So we basically put all of that data together to train these models using a specific type of deep learning that Taylor mentioned, which is using convolutional neural networks. So I'm not going to go into detail exactly about how that works. We can go into that if anybody wants to. So in addition to training models for specific mutations, we can also train models that have mutations that lead to activation of a pathway. So in about 40 to 50% of rhabdomyosarcomas, there's a genetic mutations that directly leads to constitutive activation of the RAS pathway. So these patients don't necessarily have a better or worse prognosis, but what's important to note here is that this RAS pathway is becoming more and more druggable. And so there's a lot of work being done in the rhabdomyosarcoma field about how to target RAS-activated rhabdomyosarcoma. So again, this is a great opportunity in the diagnostic setting to integrate new therapies earlier in treatment and identify who these patients are that might be responding to a more targeted therapy. So one thing that you could, a cynical way to look at this is we're predicting mutations. So ideally in the next 5 years, maybe less, all patients, at least in the US, will have their tumor sequenced. So we will have a really good genetic understanding of what the driver mutations are and incorporate that information into risk stratification. Outside the US, it's certainly going to lag behind. It may never catch up. So there's definitely going to be continued utility for a predictive model in those settings. But at least in the US, we do hope and expect that next-gen sequencing is going to become routine. And so we're going to miss fewer and fewer and fewer of these mutations. So one of the questions that our group had was, what can we do using AI that we can't do currently? And that was what we did when it came to doing risk stratification. So on the left-hand side is risk stratification for about 250 different fusion-negative rhabdomyosarcoma patients. And so this is the actual clinical risk group that takes into consideration all of these different important clinical criteria like the tumor size, their disease, primary disease site, metastasis, genomic findings, and some other things that all get taken into account, and then assigns those patients into different clinical risk groups that determines their course of therapy. So as I mentioned at the beginning, risk stratification is really where we've made the most inroads in outcomes in rhabdomyosarcoma, but also just in the pediatric field in general. And so how can we improve risk stratification using these neural networks? So what we did was we took the diagnostic H&E images and fed them into a neural network along with the event-free survival of those patients. And using that information alone, our trained AI model could output a risk score that we can use to re-stratify the patients. So on the right-hand side is the risk stratification of our trained AI model that only takes into consideration the diagnostic whole side H&E image. So what we found was that, particularly for the intermediate risk group, there is a substantial improvement in risk stratification for those patients. And so we can talk about how those models work and what they're actually seeing in the tumors. But this is kind of the future as we see it.
Thank you.
I feel like a bit of an imposter here because, as you may have heard, I'm a lung cancer doctor, primarily adult oncologist. Yeah, we all have lungs. This is true. Anybody, and we do say anybody with lungs can get lung cancer. And that's actually a really important point I'm going to talk about here. So this is amazing work using multiple different types of models and approaches and integrating data all the way to clinical care. So I'm not speaking any different, right? And I think an important point that we've all discussed is, and you'll see on my last slide too, is that we can do all of this without AI, but with the volume of data that we expect with sequencing all pediatric sarcomas, all pediatric cancers, we're already seeing that in lung cancer. It's required to treat first-line advanced or metastatic disease and even early-stage disease. We already have this data, and there's more data more than being clinically reported. So what do we do about that? And this is where data drives our precision oncology research. This is kind of the traditional model, I would say. We have electronic health record like Epic, where we employ eager med students, residents, fellows, and attendings to annotate information to specific clinical database, right? We identify patients where we want to monitor their toxicity to lung immunotherapy. We want to look at their molecular profiling data And we want to identify those complex edge cases through a multidisciplinary clinic where we can gather and extract as much information from right side sequencing data, imaging data, pathology data, therapeutic relationships to outcomes. And that might be infusional therapies or radiation-based therapies. And this model really centers on the person work in the middle. And our technology should not replace that. It should just enhance that by allowing integration that enables precision oncology research. So I'm not going to speak to any one specific project on this slide, but I'll highlight one a bit later. But I just want to tell you that I'm thankful and lucky to have a bevy of data, which I appreciate that my colleagues here may not. But we still don't do enough. There's data from ASCO every year, the American Society for Clinical Oncology, where we're sequencing patients' tumors, and up to 50% of the patients are getting the appropriate match therapy. Pretty embarrassing, right? We actually have the data, but we're just not integrating it into the care yet. So integration is really important. We have about 30,000 patients with thoracic cancers in our registry of our lung cancer precision medicine center of excellence. But as you can see here, we've only annotated about 1,800 patients with useful clinical data and made a review of their genomic data, and really not anything deeper than a pathological diagnosis and maybe whether they had metastatic on an imaging. So, we can get access now to more and more information from almost 3 million progress notes, of which a large number of those are oncology notes because we write a lot and take care of our patients, right? And also about treatment information, longitudinal information over time. Taylor talked about using liquid biopsy. This is something we use for response assessment cancers now across the spectrum. The MRD settings, we like to borrow that language, my colleagues as well, all the way to how you can detect response to immunotherapy earlier than imaging alone. So I believe AI can bridge this translational divide where we think things really fall apart between the clinic bench. And it's really about data. So we're generating so much on each individual patient. So I highlighted here where we have use cases where AI is already embedded, like from a clinical setting. I put right next to Epic in the middle here that we're using a company's technology called A-Bridge to listen to our conversations in clinic and extract using automated speech recognition and large language models summaries that go into our clinical notes. What if we're using NLP and Gen AI to curate that data? We're having AI tell us what we're saying and then having AI extract the information from those notes as well. Like, how can we do this better, right? We're putting this in places where we need to integrate better. We use multimodal AI and other strategies, as I'm showing here, many aspirational ones, to look for things like molecular twins for patients with rare subtypes of disease. So I'll just highlight that now. I'm really interested in using approaches like synthetic lethality for rare diseases. And SMARCA4 has been a thorn in our side as far as its deficiency and pathological variancy lung cancer. It can range from undifferentiated thoracic cancers to rhabdoid to sarcomatoid to small cell to non-small cell. Why? What else are we missing by just looking at a genotype or looking at an IHC that shows deficiency? So here we really want to use advanced, talked about CNNs and also variation autoencoders that do specialized variant annotation to look at how variants may modify Sweet-Smith complex chromatin remodeling, because the link here is genomics to epigenomics. We need to see how those changes really matter. And then if we can link that based on, as you noted, pathway similarity, not just based on are the mutations in the same spots in genes, but how are we affecting entire pathways? Can we use models that look at multi-level pathomics as well to look at histopathological variation to predict which patients may have more aggressive cancers and also look for that lineage plasticity we're saying? Why is that happening? Does that happen also when we treat our patients? And that's the last part, right? The whole goal of this is to summarize information that we learn, apply what we broadly understand, larger phenotypes to smaller phenotypes to predict response, guide treatment decisions. And lastly, improve trial enrollment. I think this is a huge boon. We can take information that tells us this is an aggressive tumor. We need to think about strategies up front to address that. We can improve our trial enrollment and hopefully outcomes for patients. So I'll leave it at that, but happy to participate, even though take care of mostly adults.
We are very glad you're here, Joe. So thank you. And just a few quick thoughts from that. I mean, I think that was a great summation of a lot of different aspects of work and how we're currently doing it. And I think one of the big things that came up was that there is a massive amount of data that we're underutilizing. And I think that comes not just to, can we make sure that the other 50% are assigned to proper treatment, but also even just thinking through how we look at our next generation sequencing. So for instance, in liquid biopsy, we talk about read coverage, right? So we will say, oh, it's a 12x coverage, meaning each base pair should be read 12x. That's an average though. But when you look across the genome, there's going to be dips where you have less coverage. It's 3x there. We used to always think this was artifact. But by looking at these patterns currently, what we're acknowledging and finally beginning to realize is that this actually reflects chromatin availability and is really good. In fact, for us, it's our best discriminator of cancer versus non-cancer. And it also helps us figure out where that came from. You can figure out the tissue of origin based on certain signatures that we know exist. So I think these patterns are just going to continue to come out as we have more and more data to train. And all of this garbage, what we think is garbage right now from our sequencing data, actually probably has biologic insights. I think the other part too is it's not just trial enrollment from what you're saying, Joe, but in pediatric oncology, one of the things that we struggle with is that it is all pediatric cancers are rare cancers, right? And so it can be really hard because if you have a few people on a trial who might not fit your typical bin, or it may look like there's not a lot of response. And so a drug that might be effective for a high percentage of people actually gets shelved before it even has a real fighting chance. And so I wonder if, as we start to really characterize these patients better, whether that will help us risk stratify a little better and figure out how do we put them on the correct arm of this trial so that we see the signal that was there, but historically we've just had two. And if people start to have questions, that would be great. But I think one question for, yes, for Gita, yeah.
I think these have been beautiful examples. So one question I have for, I think, David, when you talk about COG, are there efforts potentially for all of the, diseases that we deal with, potentially to apply what you're doing for rhabdo? And then, but you said, Taylor, you need to have a representative population. What is needed to confidently use it clinically, and who declares it, and kind of clears it? That would be one question, but I have plenty more. So,
Well, I'll answer the question directed to me. So yes, there are some efforts to expand beyond rhabdomyosarcoma. Not necessarily in our group. We're doing a little bit with Ewing sarcoma and some spatial transcriptomics work, but really one of the big limitations that we have is just accessibility to training data. So a lot of these different sarcoma types or pediatric cancer indications, they're pretty rare. So in our case, we had like a little over 300 rhabdomyosarcomas. We've now expanded that. We're getting closer to 1,000 rhabdomyosarcoma patients, but having access to both image data, clinical annotated data, and genomic data, all for the same patient, continues to be a challenge. And there's not necessarily an easy solution to that, although there is a lot of centralization that is ongoing for trying to make the data not just centralized, but annotated and formatted in a way that it's accessible to people that want to build out different machine learning models.
And what I would like to add there is I think we heard a lot about the obstacles, but what are some of the opportunities to look forward for that? Because we do have a lot of data, but we have very little data at the same time. The opportunity that AI brings into this, or something that I like to call accelerated intelligence, because AI scares a lot of people, right? Is that we can actually learn a lot from the large amounts of data that is general, that is not specific, to create what now is foundation models. We talk a lot about that, and this is a direction where healthcare is going as well. This is what we learn from Gen AI, right? When ChatGPT came out, that was like a new revolution within artificial intelligence, and one that impacted all of us, because we all seen the impact of that in what we do daily in the society. But what that shows is that you can learn a lot from a lot of data and a lot of noise. And then it's really important to become smart when you look at rare diseases and to fine tune that information to something that is very underrepresented, has limited amount of data. But this is what we do. And I'll give an example there. When you train a radiologist, right? You go to med school first. Well, first you grow up and learn about the world. Yeah. So like, oh, this is what the world works like. Then you go to med school and learn about the human body. Then you do your fellowships and residency and learn about imaging. And in the end, you specialize and you become the best at one type of imaging. AI does that too. So here in the room, we have so many different faces. If I would like to characterize your faces with AI, first, I would use a database from the internet to look at billions of faces. Then that can become smarter at identifying who is in this room, and then eventually would look at kids, right? And learn much, much faster, just like clinicians do too. They specialize, AI specializes too. And that's an opportunity to use lots of data, but then to smartly look at something small. You ask about something about privacy, right, and sharing, and we all love centralized repositories, right? We all love to have data from everywhere, but not everybody plays in the sandbox. And in rare diseases, then you'll be left with a very small data set. And this is where AI also brings other opportunities in working in a distributed way. You may have heard about federated learning. This was I was showing about a study where we only had a few kids out of many, many adults. This has evolved a lot. And I think right now the community is much more ready to embrace this. What does it mean? That the algorithm comes to you and you use it locally and you never share the data. But the algorithm does get smarter because it worked with you and it worked with the NCI and it worked with Johns Hopkins, and it collects information that is not identifiable. It's not directly patient data, but it does get smarter. And that's a way to actually get cumulative data from many, many instances without compromising privacy.
No, I think that's fantastic. And just to give a concrete example of what you're talking about, learning from these large data sets and applying it to rare diseases, David, I think you and same with us, so when we're doing these pathology slides, we use a unit encoder, which is a foundational model built on lots of histopathology, not from Rhabdo, not from NF1, but then we fine tune that using this larger knowledge that is already there to our rare disease.
Yeah, so just putting some numbers on it. So like Page AI, for an example, it's trained on over 1 million H&E images, both malignant and normal tissues. So that is a really useful tool that basically defines what types of features could be present in your sample. So you can take a pre-trained model like that that's very robust and has the capacity to recognize tens of thousands of different features, and then look at your rare samples where maybe you only have a few dozen or a few hundred. And by pre-training those models to see what types of all the diversity of features that could be present, it's a great launching point for developing models for rare diseases where you have kind of limited sample sizes for that specific subset of patients.
Yeah. Right after this meeting, I'm heading to Texas to participate in a research endeavor called the Cancer AI Alliance. And it speaks exactly to what you are referring to. This is where 4 cancer centers across the country are coming together to do federated research. And we all appreciate that we don't have the same data internally. We have very disparate types of data. And I think of it as like possibly the worst sparse matrix ever, right? It's like we have extreme depth as far as, TPMs as far as transcriptomics at Hopkins, and then another institution has depths of genomic data that we may not have organized already. But the idea here is to share these models in ways that, importantly, I think, Taylor, as you mentioned early on, protect our patients too. So we have to be very explicit about when we take a model, fine tune it, what goes back into the model. And one of the things we've learned through research is that there can be PHI that lands back in a model too. So we have to be really explicit about how we do this and approach this. And we're thinking about, novel ways to use AI to even navigate these challenges, right? Like a student teacher model for how we train and then implement and retrain a model using external data sets that are safer, yet have a depth of information that fills that matrix a bit more. And so the strategies to do this are centered on organizing information, but also dealing with the fact that we may not have that consistently across every institution, yet enabling perhaps a multimodal model that integrates pathology information and genomics with just enough what you might have in your institutions to still be useful, right? This idea that you can generate an AI model to really think about risk and that associates with clinical outcome better than the clinical criteria we had before. My hope is that we don't need every single piece of data at every single institution, right? If we do this right, we can inform those models in ways that really allows us to talk to patients about what risk means, to think about what strategies we can take as approach. And that's really exciting.
And if I can be the optimist in the room, technology can solve all those problems, including not bringing PHI, dealing with noise, dealing with incomplete data, because you bring something very important there. We always have things that are missing, and these models have to work under those circumstances.
Hi, I'm not in the medical field, but I'm in, my expertise is in business intelligence, which is very much data driven. And I very well understand that good intelligence starts with good data. We're also trying to align AI with business intelligence. And I really appreciate what you're doing with trying to align AI with pediatric oncology. How much confidence do you have in AI diagnosing the heart conditions in kids? I saw it in one of your slides, but I was trying to understand how much confidence level you have in AI doing that kind of diagnosis in kids.
I think that may be targeted to me, and that's a very specific example I showed there, which is rheumatic heart disease. If you use a standard machine like we have at Children's National, right, which costs $250,000, the AI model has 92% accuracy. If you use a portable machine that costs $3,000 and is much more accessible in other places, we are still learning about that, but we're at about 85% accuracy. A cardiologist has something between 80 and 90% accuracy in identifying early conditions of rheumatic heart disease. So this is not to say that this will always be consistent like that. And what I would like to add to that is that what we have to be very careful is that when we implement AI in the clinics, there are at least three things that I think are really, really important. One of them, there is a cultural shift in working with algorithms and with machines, and clinicians, like many of you here in the room, will have to trust that, to adopt it, and to be comfortable with it. At the same time, people who develop those algorithms will have to be comfortable working with you. So that's something that doesn't translate just from a study into practice. There are the computational shifts as well, because hospitals need to be ready to run these algorithms, which means data scientists, GPUs, and clusters. Many are investing in that, not everyone is doing it, and regulatory aspects as well, because these are algorithms that are changing and have to be governed by some regulator.
Thank you. I was wondering, is it possible when you're looking at thousands of H&E slides or liquid biopsy, for example, that the AI could be trained and be recognizing features that are not strictly on the causal pathway of a given disease that we're worried about? For instance, like a certain mutation might lead to some kind of nuclear phenotype change, and that might recognize that, but maybe it's picking up on some ancillary details and classifying patients as high risk. My question is, can that be happening? And really, does that matter?
I mean, yes.
Yes.
Yes. But if you think about it, it also happens all the time doing traditional wet-based laboratory work as well, right? We go on wild goose chases after pathways that seem to be really important, and we realize that it's actually not, that protein was not important, and it actually didn't matter to the ultimate model or to our predictions. So I think that exists. And I think one of the general things that I think about is that that AI does make mistakes, right? Like, I mean, Marius's arm is coming right out of Joe in this picture, right? So AI makes mistakes, but individuals make mistakes as well. And I think one of the important things, and I'm really sure what you guys think about this, is trying to develop a better understanding of the technology that we're using so that you can see that mistake and understand how to interpret it and to take everything with a grain of salt if you're starting to train, testing everything multiple times, multiple rounds of validation, not just using a single trained data set and saying, look, we've got a great predictor, right? But yeah.
But actually, causality matters. And here I'm actually paraphrasing a friend of mine, Ben Glocker, who is a professor at Imperial College. And he actually wrote a great paper about causality called Causality Matters in Artificial Intelligence. And I think that's also, it's very interesting identifying potentially new patterns as well, which, as Taylor very eloquently said, need to be checked and need to be understood. And putting that kind of interpretability in AI is important. Actually, there is a big paper, I was part of it as well, but it's from a consensus of over 100 people that wrote a paper called Future AI. This came out in the BMJ in January or February this year, which puts out what are the criteria that should be thought about even before you start thinking of developing AI, not just implementing in clinical healthcare, to get trustability or trustworthiness into implementation. And it's really important that we understand this and we keep refining this. And actually, this future AI, I think it's a dynamic thing. It's not like one paper came out, read it, and you're going to be a genius about it. No, it's a process about doing workshops, about doing training, about changing these criteria because they will change as technology is changing too.
I like the causality matters title. I mean, it's in direct contradiction or not contradiction. It just changes the viewpoint of, the 2017 paper that attention is all that matters, right? From our transformer technologies. And it's just a reminder that if we are to invoke this in a clinical setting, right, we really do have to be paying attention. So just an example of what you're describing, we took unbiased sequencing data from 2 different sequencing platforms and developed a bunch of different models by looking at variant calls. And one of the things that we identified is how different those platforms just sequence and call variants, right? And so we could easily make a discriminator, ignoring that they have different panels and things like that. We're trying to merge this information. We could easily make a discriminator that would say, oh, you use this sequencer versus that sequencer. And of course, if you ask like the individual in the lab who's interpreting that all the way from the bench to the molecular pathologist, they're like, yeah, we just, we ignore that stuff in IGV, or we don't call that, or we don't include that in our reports. But I think what you're saying, there's 2 parts of it, right? There's one, a discovery part. So if that's happening, we might be missing something to discover, right? And on the flip side, there's noise everywhere, right? And I do agree. I'm a skeptic. I mean, as a scientist, I have to be skeptic. I'm enthusiastic as well. But the idea here is, how do we focus our attention on both? And how do we use these strategies, these AI-based approaches, to have that cream rise to the top, right? To identify things that are just inherently noise within the data that still are signal, right? And what the signal to noise is deep within these convolution networks, right? This idea of interpretability is actually really hard. Right? We can kind of get viewpoints into it, and we can get examples out from what a prediction is. But even just having ways that we interpret the interpretability, like being able to develop interfaces and utilities, and like how to translate that into what what you highlighted is, in the end, we're trying to make what the FDA wants to call a device, right? So there's got to be a lot of proof in the pudding if we're going to put that device out.
Hi. Thanks so much for those great presentations. I also am a big fan of big data and systems biology, but then also appreciate that with any computational prediction, you really need to vigorously validate. And in something like pediatric cancer, where all of you have acknowledged that there are smaller training data sets, right? Like what are some creative ways that we can do to have validation data sets, right? If the training data set is already very small, like what are some ways we can validate the predictions, especially in pediatric cancer? And then also, what are some ways that you guys see use to validate in the real world these predictions? Like how do you define as ground truth? Like and how would you apply that in the pediatric oncology setting?
Maybe I'll start with something just to show that how perplexed I am about this question as well. Because theoretically, if you ask me about validating things, I think like many others, that we should have a model that fixes everything, right? Pediatric cancer, we're going to have the best model that identifies and stratifies and deals with any kind of cancer. But it doesn't quite work well. So typically you want to do a validation set into another institution, a slightly different population, right? We're talking about different ethnic variability in the population, how important it is, and you want to see it working that way. But in practice, I actually think small models work better. So if we know that we're addressing a condition where we have a model that works well in a small space, in a small population, but it works really well there, why should we ask it to work well in a completely different population, right? Where it will fail. But that kind of definition really comes to the subject matter. Do we have a validation set, and do we have a population on which we can focus well, and we can have the right safety check marks for that population? Then I think we can stop there. We don't have to solve all the problems of the world with one model, but we can have lots of small models that work very well in these populations. That can be differently for populations that share some characteristics and diseases that share some characteristics. And I think that we can aim higher and have a broader validation.
I was just going to echo what Marius just said. So there is tremendous value in making your models small and specific. So in the case with our RAS pathway prediction, there are 16 different genes that are mutated that lead to activation of the RAS pathway. Those different mutations are not equal. So they might all lead to activation of the pathway very directly, but they're not clinically equal. So when we lump them together and we try to train a model that can predict RAS pathway activation through any one of these mutations, that model barely performs well. I mean, it's good. It's better than chance, but it's not perfect. And I think you're just adding noise and complexity by trying to make a model more expansive and encompassing rather than making it very specific to the question. So I think a lot of high quality small models is probably a good path to go.
One place where we learn this, well, we just continuously learn it, I guess, is that we often have data sets that have few rows, but millions of columns now, right? And this idea that, I was talking about the sparse matrix, right? We're filling this out in a way that doesn't, we're not grasping the fact that we need more rows, I guess. And so one thing that I think is compelling, I don't think it's prime time yet, is the idea that we can probably generate, some maybe patient level characteristics that we can generalize using, subsets of information to increase our row level information. Maybe not with as many columns as we'd like. And this can be a way, although it is fraught with challenges and overtraining and everything else that we've learned from machine learning, but it could be a way that we could use generative AI to develop things like molecular twins for patients, clinical cohorts of patients that can be used for testing, and also really to do things rigorously like identify when we've overtrained a model, right? And so if we're making, a totally fabricated data set and it's doing an excellent job discriminating something, well, maybe we're putting too much in the model. I think the key here is like taking away the fact that we've learned so much from foundational models, focusing on how we can implement those back in settings where we're data poor. I think that this is where, again, AI in many ways we can use strategies that are based in machine learning to really do that.
Optimist in the house again. So
I'm very optimistic about it.
Gen AI does that, and it's probably not prime time because it's not embedded everywhere, but it does that very well. And what is also quite interesting there is that by introducing a little noise with generative AI, you actually help some of these models becoming more robust and avoid some of the overfitting and the overtraining, because you can generate anything and everything. You have to stop something that is relevant. So you have to have a good mechanism to understand how you generate something that is useful for training a model. But the fact that you get a model to be exposed in the case where you have 5 rows, right? And you're going to have 5,000 rows all of a sudden. That will help a lot with that generalizability where models become a little better and more robust to other situations that include noise too.
And at least in the NF1 world, we've had conversations with FDA, and they have been very receptive to the concept of using synthetic data. Rare disease. I think there's a willingness. It's obviously something that is not prime time yet, and
Actually, there are a lot of programs right now that are funding that. The European Commission has the biggest funding program this year in healthcare and generative AI. Wellcome Trust just had out a call where they want generated health records for mental health. So this is, and I would say that with just a small disagreement, it's quite prime time. It's not quite implemented everywhere, but technologically it is prime time.
Vandana.
Yeah, thanks again for this great session. Vandana Akshantala from the NCI Pediatric Oncology branch. I really appreciated how you covered both like the optimism and enthusiasm of what all can be done, but also like all the things one has to be very thoughtful about. So one of my questions on that, I think maybe more specifically for Dr. Linguraru would be, when you address the issues related to the privacy or the ethical concerns, particularly when you're working in, like you showed examples of in many different countries. So one question I had was there anything that helped facilitate this or any specific challenges in terms of working, I guess, more internationally? And the reason I bring it up is, that's something we're always struggling with rare diseases. And one way of, adding numbers would obviously be if we could collaborate across, borders, but they will obviously have more specific ethical and regulatory things that come up when you're trying to do that.
That's a great point, and I can speak only from my limited knowledge about that. But adapting to the local healthcare system is really important. So we're talking about language model, generative AI. You personalize a GPT to something that is local. And that comes with a lot of cultural connotations, right? For instance, we developed, part of one of the grand challenges of the Gates Foundation, we developed a large language model for education about non-communicable diseases in the Kenyan youth. And this was something I definitely wasn't qualified to guide, right? And what came out of that was really important because we did surveys and we engaged with advisory boards and so on for a while. And the language had to be, it's something very different than what we think we do over here. But this is how you gain the trust there, and this is how you get the engagement as well. And these models also learn over time. As people engage more and more with them, they become more and more specific to that. That's one thing. I was mentioning earlier one of the things where, the portable MRI machine, and this is in many locations used in Sub-Saharan Africa, in South Asia, and right now the first one is going to Latin America. And each one of these locations uses it very differently, and their needs are very different. And what is also spectacular is how people adapt at using things way before we are ready to adapt them over here out of necessity. So this is something that I think it's a fantastic opportunity, but again, has to come with something like what are the safety checks, and people are deciding on that differently. And this is their territory and this is their clinical care, and they know better than what we do when we work with them.
Thank you. And if I may, I had another question for Dr. Milewski also. When you described your rhabdomyosarcoma analysis from the H&E, many times, it's the samples we may have are biopsies because you don't resect them. And another thing that comes up is obviously intrapatient, intratumoral heterogeneity. So I was just curious if you had looked at from a same tumor, if we were to have 2 biopsies from different parts, would your analysis is that something you've had the opportunity in your data set to look at, I guess?
Yeah, we have looked at it, and there certainly is, heterogeneity. The AI sees heterogeneity. So there's different ways that you can have the AI show you where in your sample it pays the most attention to. So like attention maps is one commonly used way to do that. And so it does make a difference if you have a limited amount of tissue, like if it's a core needle biopsy and you just have one core and your entire interpretation of the tissue is based on that one core. Certainly there's going to be some bias in the interpretability of that. And there's probably not easy ways to get around that beyond just having a robust training data set where what types of variability you can expect in that type of sample, and then just train the model to recognize all that variability.
And I know that at least in some of the neural networks that do that, so like CLAM, for instance, they actually have different models that are trained on biopsy or full resections to try to account for that variability. But obviously, it's not a perfect fit given the actual tumor heterogeneity that you'd have. And Chalice, you've been trying to get our attention for a very long time. I think you get the last question if you'd like.
Sorry, thank you. So I'm Chalice Donovan here from Hopkins. Thank you all so much. This is absolutely fascinating. I think, obviously the true promise, but also a considerable challenge is that we really don't know what we don't know. And so ideally we have these huge data sets of all the molecular and clinical data. But as you've heard over and over, and Joe, especially in pediatrics, we just don't have the patients. And then we also don't have the patients that are willing to consent. And the IRB is really asking for specific information about what we're going to do with all of the data that we're collecting, and especially if it's genomic and molecular data. So is there sort of federated or universal interpretation of the federal guidelines that you can offer to us or to COG, or that will satisfy the IRB so that we can say, hey, please, patient ABC and family, give us permission to collect literally everything, and we're not sure what we're going to do with it yet?
So Chalice, you want me to talk about Hopkins specifically? So this is where
IRB.
This is where I get angry and I take my jacket off. And, I show how frustrating it can be. Like, look, it does just take the work. So, for example, now the Data Trust at Johns Hopkins has a genomics working group, and I'm part of that. And so I can say, yes, you're using level 1 genomic data, or level 2, or level 3, which includes germline information. All these things have to be defined by somebody somewhere. And we're borrowing from our institutions in these collaborations to really come up with consistent definitions so we can share our IRB, so we can do the federated research too, right? So, from the data models that we're using to capture the information being consistent and vetted by the Data Trust and the IRB prior to implementing studies, to doing the back end work to make the collaborations work across the way. It takes effort in a way that is frustratingly slow, right? At our institutions, regulatory wise. You made a great point that at the end is regulatory. And often, if we're not doing that at the beginning, the end does not happen. And so doing the upfront work is there. I'll say it's always good to make a standard. It's terrible to make yet another standard. So we're trying our best to really focus on minimal. ASCO's definition is M-code, minimal common oncology data elements, using ideas like this to say, this is what we want to collect. This is the risk of each tier of data that we're including. Allow us to do this research in this way. And when we get this information from patients, we can at least be clear in its risk tiers, And I appreciate that interpreting that for patients is hard, but let's use Gen AI to reach them in that way too, right? Reach out to patients to talk about how we're enrolling them in studies. From the time they sign up for that new patient consultation to the second opinion to, I want to federate genomic data so every company that does it has to put it in a repository where we can access it in a de-identified way and then re-identify it if we need it for clinical care. Like, I appreciate these are blue sky ideas, but we have to start at our institutions and think about regulatory upfront. That's what I've learned. It's painful being junior faculty and having to do that. I'll be honest, but it only makes things happen is what I've realized, right? So lastly, just very specific to you, we are working to liberalize our genomics data in a way that includes patients who are younger than adults.
And I have lots of scars to share here in this story as well. But what I would say to try to stay a little bit more optimistic, right? Towards this end is that where I found that there is a little bit more empathy, right, on working with data is if you collect and make it quite clear from the beginning that you're going to use data that's been already collected for clinical care. And most of our patients are going through that, and the data is available in a system for that level. And I found there is more lenience to think that, well, this is something that already exists. You're not going to sell it anywhere. You're just going to try to do something that is going to be good for the patient with something within your system. Now, when it comes to sharing the data, that's another story. When it comes to what's happening right now, and I think many of us here are aware that there are these healthcare data marketplaces that are being built. right? And there is a lot of discussion about monetizing the data with the pros, with the cons. And I'm not saying that I agree with any of that, and that would be a completely different conversation. But healthcare systems are facing that as well, right? This is something that is coming from different directions, and the ownership of the data is still something that is very sensitive, right? And hard to approach in a conversation.
I really, really appreciate each of you being here today. Thank you so much, Joe. I know you've got a flight to catch immediately. But a quick selfie. Absolutely. But again, I know I'm sure there are more questions, and without consent, again, I'm going to offer every one of us to be available as those questions come up, knowing that it might not be today. Some of us have flights, but you know how to find us. So thank you guys. I appreciate you participating.
Thank you.